Hello and welcome to the ASCO Daily News Podcast. I'm your host, Dr. Monty Pal. I'm a medical oncologist, professor and vice chair of academic affairs at the City of Hope Comprehensive Cancer Center in Los Angeles. Now, we've all heard about the promise of large language models to revolutionize oncology by supporting clinical decision-making, enhancing patient care, accelerating research. But how do they really handle the nuance of a rare breast cancer histology or maybe a treatment refractory case? Today, we're going to explore the potential of Articulate Medical Intelligence Explorer, AMIE, a large language model-based experimental medical AI system to really augment clinical decision-making in this challenging context. And I'm really thrilled to be joined by two leading innovators in this space. You're going to be really impressed with their background. Dr. Alan Karthikesalingam is director and principal scientist at Google DeepMind. He actually co-founded and leads AMIE, an AI co-scientist, and also co-founded other projects, including MedPalm, MedPalm2, and MedPalm Multimodal. He's also an honorary lecturer in vascular surgery at Imperial College in London. Anil Palepu is a research scientist at Google Research, and there Anil actually works on developing LLM-based systems for medical and biomedical applications. He's a core contributor to the AMIE project, conducting research towards a conversational, multimodal, empathic, keyword empathic here, and diagnostic medical intelligence. Alan and Anil, it's so great to have you on the podcast today. Thanks so much for being here.
Thanks, Monty.
Thanks for having us.
I've got to start with your backgrounds. I've had a chance to peruse them a little bit. I'm blown away. So, Alan, I'm going to start with you. Medical degree at Cambridge. You got your PhD from the University College of London in vascular surgery, these wonderful, prestigious institutions, really tailoring towards a wonderful career in medicine. What took you to Google?
Thanks, Dr. Pal. We've always been very focused on the care of the patient and trying to make that as good as we possibly can. And especially in a specialty like vascular surgery, which is quite high risk, this becomes like a very powerful motivating factor that repeats frequently. And that impetus drew me very quickly in my career to research. So alongside my clinical training, I was fortunate enough to, not only do my own PhD, but receive research funds and supervise PhD students and other things. And it was in the course of doing that I started realizing that data and the analysis of data just had tremendous potential to bring about very profound improvements in the way that care is delivered and in really solving many aspects of diseases beyond just the delivery of care itself. Honestly, it was just great fortune that I happened to be doing that work in London at a time when there was tremendous excitement and improvement around the potential of deep learning. And I was just very, very fortunate to be able to meet with great people at DeepMind and engage early in some of that work. Yeah, I had the opportunity to go and work with DeepMind initially for a year. And to, my delight, here we are 10 years later. And it's been an incredible decade seeing the transformative potential that AI can have in healthcare. So yeah, for me, honestly, it's less of a career progression and more just like a series of privileges that seem to have come about by basically just following what I think is the path to having the biggest impact I can.
Awesome. And Anil, I'll maybe ask you that same question in reverse, because it sounds as though your career started maybe with more of a focus on the technical elements, but now you've sort of merged into healthcare. How did that come about for you?
I've definitely been quite interested in healthcare for a long time. But again, as you mentioned, sort of started from a more computer science background and did some research, using this large amounts of medical data, and was honestly very astounded by how much insight could potentially be gleaned from this type of data and how little of that is actually properly used today in practice. Especially, when I joined my PhD and, LLM started blowing up, I got very, very excited by this. That's sort of the main reason why I really wanted to work with some of the people like Alan and others who were driving this field forward and seeing how we take this technology and really push forward the field of medicine.
So Alan's been at Cambridge and at UCL. Anil's been at Hopkins, at Harvard, and MIT. So after this podcast, I'm going to sidebar you guys and talk to you about how I can get my kids into one of those colleges, okay? So if you don't mind, I'll take a couple of minutes from both of you. But that's besides the point. Today, we're here to talk about AMIE in particular. Now, first, I'd love to hear from you what makes AMIE really distinct from a standard chatbot. So we're all familiar with using GPT-4 and some of those tools. What really sets it apart? Maybe I'll start with you, Alan.
Yeah, sure, absolutely. So first thing to say is, in terms of the progress of LLMs, it's clear that is proceeding at a very rapid clip. And we see that general purpose systems are very impressive across a wide variety of domains. At the same time, the domain of medicine necessitates, it has a whole bunch of different characteristics and attributes that are particularly important. For example, the ability to reason over clinical information very accurately and communicate with empathy, with a professional tone, as well as draw down in that reasoning upon a bias towards like objective, scientific, and reliable sources and information. And so in the AMIE series of research papers, we have tried to show how we can develop systems that are kind of intentionally architected around that domain. Just sort of some examples of that include things like when we set up inference time strategies and multi-step processes so that the output of this agent in this domain can be crafted for the purpose. Like imagine drafting an initial response, then doing things like conducting web searches to try and retrieve up-to-date, but specifically clinical knowledge, and then self-critiquing the output to revise its own logic based on that information. That's one aspect. And then you'll see in our other papers on this like research-only diagnostic dialogue optimized system that as it's conducting these research diagnostic dialogues, it will do a similar form of reasoning to try and make sense of what possible differential diagnoses or treatments could be, and then formulate the next turn of output conditioned on that. So it's really those kind of touches and design approaches that we've employed that I think mark how this is different from very powerful, rapidly improving generalist systems upon which we build.
I've had a chance to do sort of a deep dive, a very important publication, I think, that your group put out in NEJM AI, this new sort of subset of the NEJM that's focused on artificial intelligence. And it looked at AMIE in the context of breast oncology. It had a very interesting study design. I've had a chance to read through the paper in some detail, but I'd love to hear perhaps in your words, Anil, maybe I'll turn it over to you, kind of how the study was sort of oriented within breast oncology.
We did the study along with some really great partners at Houston Methodist. And the study was looking at a set of 60 synthetic breast oncology cases. And these were crafted by a group of their breast oncologists who came together and tried to get us a fairly representative set of some of the different types of presentations they would see. And that includes, treatment naive presentations, treatment refractory, a couple of rare presentations. Of course, with 60 cases, it's not going to be completely comprehensive, but we do think that these scenarios are a fairly good measure of, an AI system. The goal here was essentially, we wanted to compare our system, which again is not just a model, but is a harness around this model, and see where it would stack up in terms of its management planning against various levels of clinicians. So ranging from trainees to oncology fellows and attendings. And the TLDR of that is that it did quite well. It did outperform trainees and fellows in many of the domains that we measured. But the consistent performance from attendings tended to be higher than what we saw from our system. I think it's interesting because there's certainly still headroom in this very challenging domain, but we do see quite a bit of promise from the results in the study. And definitely this points to future improvements and future optimizations that maybe can help us reach that consistent level of performance.
So, Neil, great description of the study. I'm just curious. It definitely looked as though AMIE outperformed internal medicine trainees and oncology fellows, no doubt. What do you think it says about the state of AI that we can really sort of beat folks at that level of training?
I think primarily it sort of just shows that this is a hard task. The trainees maybe lacked the certain level of knowledge to produce completely safe and effective plans. These are, again, being evaluated by breast oncologists, and they may not have that level of specialty knowledge yet at that stage in their training. But that being said, LLMs can spit out this vast amount of knowledge, and they are able to have at least a certain level of competence across a broad range of specialties. Getting to that perfect level of consistency and precision that you see with the attendings, though, is still, even though the metrics might look fairly close, I think is still quite a bit more work and research needed.
Yeah. And Alan, you've been through it. I'll ask you sort of the same question, maybe the other end of the spectrum, as you've sort of proceeded through your medical training and progressed from intern to resident to fully trained specialist. Certainly, there's a lot of sort of reasoning that was gained. And we did see that AMIE lagged behind attending oncologists to at least some extent. What is it that sort of sets that attending apart from AMIE and adds that level of clinical intuition?
Yeah, I think this is an excellent question. And you can actually see in both ends of the spectrum possibly the same trend, which is that it's already a milestone to have an AI system that can sort of surpass the lower edge of the spectrum, because you can see that suggests that LLMs are becoming quite efficient in coding and retrieving knowledge. My interpretation there is that in just fetching facts, they can be increasingly reliable and quite good. However, this point about attendings and clinical expertise, which I think is really drawn out by the very challenging cases here, is one perhaps more about clinical intuition, where there can be more than one right answer or no one right answer. But you need a lot of experience to balance factors like a patient's very specific treatment tolerance or comorbidities that might have led an attending to intentionally deviate from like standard guidelines with implicit clinical reasoning that might not be kind of directly encoded. It's another way of saying like medicine is more than the application of just clinical practice guidelines. Medicine is more than protocol following. And I think there are many examples like that of the touch of an experienced clinician. There are also some more prosaic issues that we saw, which maybe also reflects the fact that this research was also built with earlier generations of our foundation models. But there were some domains like sequencing of treatments, or where the retrieval of the information may have drawn on like older regimens that were subsequently replaced, like in these scenarios. So there are aspects like that that are probably more addressable. And then there are some slightly more intangibles that are very interesting about subtle applications of clinical intuition that very experienced physicians are just able to wield and balance much better.
Alan, question for you too, as you're designing these clinical scenarios that were tested in the paper, how do you replicate that sort of messiness of what we encounter in the real world? I was just looking at your New England Journal publication from, a decade ago on looking at abdominal aortic aneurysms, right? So as a vascular surgeon, I'm sure you probably would agree that not every AAA is created equal. In the same way, as much as we like to put the breast cancer case on paper, right, there's nuances, this messiness, as, I'll describe it, of day-to-day practice that is difficult to encapsulate in a vignette. How do you account for that?
Yeah, I think that's an important limitation of this paper, actually, that one of the really interesting things, if you think of an aneurysm, there's shorthands for an aneurysm, like the diameter or the part of the body, but then there's all kinds of infinite nuances to do with the neck angulation or the iliac tortuosity, the calcification in the vessels, the patient's wider health, their preferences, so many things. And similarly, in these cases, you can imagine that, but across many, many more dimensions. And I think while work like this is a good first staging post, there's a lot more to do. Like you can imagine actually intentional factorial variation of a lot of these cases deliberately along many, many axes where you can kind of permute or alter these cases to try and draw out some of that much greater messiness that you see in the real world. And in fact, in some of our other research, we had intentionally tried to expand the cases against which this model was effectively practicing by having a loop in some of our other papers where we had a patient generator model that would actually intentionally vary the presentations that were being presented to a kind of more diagnostic decider model, and then having the outputs of those conversations reviewed by a critic model. So that's kind of one way to do it. Obviously, I think the ultimate and best way to do this is by cumulatively studying and basing those variations on as close as possible to real world experience. But even that doesn't necessarily get to the fact that in the real world, there is always going to be a long tail. So I think this is where intentional mechanisms of self-play, rehearsal, deliberately and adversarially varying situations as much as possible is probably one of the strategies we found to be more effective.
And, Alan, I was piecing through one of the tables that really sort of summarizes the performance, right, of resident versus fellow versus attending, and of course, versus AMIE. And one of the things that really stood out to me, and tell me if I'm interpreting this correctly, is that the gap between AMIE and attending was smaller, significantly smaller, as I perceived it, as compared to the gap between AMIE and the internal medicine resident and the fellow. The implication there to me is that AMIE might be catching up with attending. I mean, is that fair, or do you foresee a circumstance in which we as oncologists should be sort of shaking in our boots about becoming replaced?
I think, again, we try to keep these things in perspective somewhat. There's an awful lot more to being a physician, especially an attending oncologist. That is a tremendous array of like vital competencies and responsibilities that were not at all studied in this paper. And I think another thing that's important is that like the calibration of these rubrics or these metrics was not really designed to show how close is an AI system on the path, if there is even a linear path, in acumen between a trainee and an attending. So I would maybe look at this another way, which is that one of the things we would really hope is that systems like this might, if we keep studying them and trying to intentionally improve them, we can learn how to make them more useful and more helpful to physicians. And we've got this kind of long history of studying the complementarity between people and AI systems. That may be more where we see these results pointing, which is that it seems quite clear that particularly in safety critical domains like medicine and high stakes ones, even further so like oncology, there's a need to be like very, very respectful about the need for professional, accountable decision making in the care of real people. And that's something that should be taken extremely seriously and with careful approaches to regulation and evidence generation and accountability. At the same time, some of the promising performance that we can see here in safe, ethical research settings does suggest that maybe these tools could be useful in terms of retrieving appropriate decision support or finding the right guidelines, maybe even helping in educational settings, and also perhaps helping to bridge the gap between physicians and patients, because they can be very kind of fluently communicative and really help like bridge that doctor-patient relationship. So these are sort of several of the more promising avenues that we see without really having to call into question things that actually lie a bit outside the bounds of our research.
That was a wonderful response, but help me, because I every now and then, particularly when I'm doing a podcast on AI, I sort of think about what the impact is going to be, on the futurescape of oncology. But I'm sure this is something that's at top of mind for you all the time, Alan. And with the exquisite background that you have, I think you're probably best positioned to tell us 10 years from now, pull out your crystal ball. What is all this going to be towards? How is the physician going to interface with AI? Give us your best prediction.
I actually think for oncology as well, it's also a field in which scientific discovery is extremely important and is proceeding at rapid pace, also augmented hugely by AI. And 10 years is a long time, full stop. But given the progress of AI in the last year, 2 years, 3 years, 10 years is an extremely long time. So we could afford, I think, there to be quite optimistic. If these systems keep improving and if they can become ever more trustworthy, ever more reliable, then it might well be that actually the practice of medicine with AI tools is just viewed as standard and as expected, and that they are known to be safe, they're known to be helpful, and they're known to improve care quality. That would be fantastic on the one hand. And on the other hand, that actually the nature of care which is being delivered is being accelerated tremendously by the derivations of new therapy, by acceleration to scientific discovery. You mentioned the Co-Scientist Project earlier. We're already seeing that these systems can radically improve the range of an expert scientist's hypothesis generation capabilities. It can help move science forward at digital speed on the one hand. And then we also see that in other areas like the understanding of biology towards the development of new therapies, AI is also now being very helpful. So across the stack in oncology, if we take everything from the better understanding of previously intractable diseases to the development of breakthrough cures, to the delivery of more accessible, more available expert care, I actually think that over 10 years, we should see AI being routinely expected to radically improve that. And that should, hopefully, we'll see that translates to much better clinical outcomes. That would be the take.
Brilliant. That clinical piece, how we integrate, really comes to top of mind so much. And the one piece that I perceive to be a big challenge, we've highlighted this term from the outset of our podcast, is empathy. How do we create an empathic response from AI? Sure, you've probably had vascular surgery patients who come into the clinic and they've done their online calculators to look at morbidity and mortality for surgery from 5 centimeter versus a 7 centimeter versus a 3 centimeter aneurysm. Take that and magnify it by 10 for what happens in the oncology clinic. Everybody's done a very vast and expansive literature search. And sometimes the outputs from that can be quite challenging to take emotionally, right? How do we make sure that a machine, an AI interface, can provide the patient with information in a manner that is digestible and appropriate and conveys the sort of sensitivity that we hold in highest regard in oncology?
This is another great example of why we are very cautious on the responsibility and great acumen of what it actually means to be a physician as opposed to building tools that can augment physicians. There's a question here of scope also around empathy, where perhaps there are certain types of news or certain types of conversation or certain types of decision that it may just not actually from first principles be desirable to have delivered by an AI in their current form. And that can include things like, as you mentioned, the final decision for accountable treatment, a really complex oncological case. Whereas maybe in terms of empathy, there are other aspects where these systems have particular strengths. So one can be the fact that they're continually available. Another can be the fact that they can rephrase things very, very well and very eloquently. And they can also adjust for comprehension and adjust for kind of question answering to a person's needs in many different ways and repeatedly over time while staying consistent with a defined plan. And so I think with things like that, there's great potential to augment empathic care delivery overall if we think of hybrid or triadic systems of care where people are actually augmented by AI and we can think through the complementarity between AI and expert physicians. And so I think a lot of this is about, again, how physicians will use AI systems best and how actually we can build AI systems increasingly to imbue those necessary capabilities, but then actually how care delivery systems can explore using them in various different workflows and pathways where that's the aim.
Yeah, brilliant. I love the idea of sort of setting boundaries, as you highlighted, around where, empathy is delivered, perhaps most abundantly by the clinicians who's interfacing with the patient. And I do think that argues for sort of a preserved role for the oncologist in this interaction with or without the involvement of AI. Think that makes a lot of sense. The other thing that struck me in the paper, and I'm glad you guys touched on this, are rare scenarios, right? Specifically in your publication, you highlight rare histologies of breast cancer. Alan, I'll turn this to you because this is a bit of a nuanced medical scenario, but envision us, using the AMIE tool for a patient who has advanced kidney cancer, which I specialize in, but an incredibly rare subtype, but paired with, for instance, a very complicated aortic aneurysm that theoretically needs repair, right? I'm going to pull from your world of vascular surgery. How do we get AI to address these scenarios where ostensibly there's probably a data void, right? If you look at the published literature, I was just pubmetting this and I didn't really see much to address a scenario like this. And where I would say in day to day practice, we probably lean a lot on clinical intuition and dialogue between experts. Usually, if I saw a patient like that, I'd probably say, let me get Dr. Karthikesalingam on the phone and figure out what to do. How do we get AI to fill those voids, or can we?
Yeah, I think that's an excellent question. And again, it comes back to this idea of AI being a very useful tool for physicians. So if we take that case that you just outlined, there's a balance of risk now between two quite serious situations, and each probably needs independent appraisal along all the axes that define it. So if you take the aneurysm, the morphology of the aneurysm, the size, the diameter, the patient's wider life expectancy versus their operative risk, and then obviously their preference. But in terms of the absolute decision to proceed is kind of going to need appraisal of all those things. And I think one thing that AI could help in that case is even in structuring that thinking, retrieving where it can some of the relevant information and calling out where other relevant information may not necessarily be to hand. So I think another good thing about these systems can be structured information acquisition. Having said all of that, their ability to necessarily then like expertly interpret all of these things. Like I'm kind of, for example, today unaware of systems that can scrutinize a CT scan as well as a like complex medical file and then opine authoritatively on open operative risk, for example, because, I have just never seen a paper that's even attempted to do that. Attempting to train such a system would need a lot of different kind of experiential data, like what it's actually like to open those hostile abdomens and deal with the adhesions. So many things to think through there. A good system would actually know that opining on that specific axis of risk is not necessarily something that can be done from the literature or from the medical record or from imaging alone. And it might need to call on the opinion of an experienced and expert surgeon who might be able to actually physically examine that patient and view the relevant information and then input that, right, as a variable to be considered into this like structured decision-making process. On the other hand, for the oncology side, it's possibly also similar, isn't it? If, for example, we can harness the strengths of these systems with the ability to know their limitations. So take the aspect that you mentioned about it being a particularly rare tumor, maybe one for which there isn't level 1 data, sort of extremely directly applicable randomized trial data and so forth. But perhaps such a system could surface not only that, but then maybe even ideas for what sorts of other tests might be relevant in that case, whether there are relevant earlier phase trials that could be applicable to explore the uncertainty space and so on, and actually help bringing the information together. And going beyond that, when you mentioned about then dialogue between experts, that would also be a very interesting use of these systems actually to facilitate such multidisciplinary discussions, particularly where like the remit of them might go beyond, because it's a rarer case or you're crossing specialty boundaries, maybe even crossing institutional boundaries, like facilitating that productive dialogue is also, I think, something that people are now using LLMs for quite a bit outside of such complex medical settings, but could be explored in them. Would actually be a very, I think, very productive way to use them.
That's precisely where my mind was heading with this, because in this scenario that I gave, metastatic renal cell with a complex vascular surgery issue, I think of my hospital, City of Hope, which is one of the best and biggest oncology centers in the US. But we actually have, one vascular surgeon on staff for our entire population. It's just probably not necessary on a day-to-day basis. But when these complex situations arise, I'd love to use an LLM to really sort of get in touch with somebody with your level of expertise and forge those connections. So I see a lot of relevant output. This has just been a tremendous conversation today. Anil, Alan, thank you so much for your time. Really appreciate the dialogue today on Ask a Daily News.
Thank you for having us.
Thank you.
And thanks so much to our listeners for your time today, too. If you value the insights that you hear from the Ask a Daily News podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.